I want to welcome everybody to our first Friday seminar series session of the spring semester. And we, along with Susan Van Nessen-Scanlon and Jen Ibrahim, we are actually really excited about this session, as well as two other sessions that we have scheduled, one next week and then one later in the semester, where we're really going to spend a good amount of time this semester engaging in some interprofessional education activities and bringing our community together across our disciplines to really look at a number of issues in public health and then set the stage for things that we can do in subsequent years where we really learn from one another and kind of meet in the middle, whether it be around a public health problem or a clinical case, and really learn from one another about how our disciplines do the things that they do. And as we were thinking about how to best do this, we thought that one good way to start would be just to kind of with some level setting and to really reintroduce our disciplines to one another. Because as we know, oftentimes our families and our parents have no idea what it is that our disciplines do. You know, we tell them we do this and they just kind of look at us and give us that blank stare and say, I understand, and we know that they really don't. But I think we would all agree that sometimes even within the college, we don't know what our different disciplines do. And so Jen stumbled across this great idea of why don't we do a takeoff on The Masked Singer and The Masked Dancer, those shows that are quite popular right now, and do something called the masked profession. And so what we're going to do today is we've got 8 or 9 members of our faculty who have put together essentially a quiz question for all of us, which is a more of a tongue-in-cheek description about what their discipline does. You all will have an opportunity then to guess in the poll feature what that discipline does and what the correct answer is. And then a faculty member from that department or that profession is going to come on out and actually explain to us a little bit about what his or her field actually does. And I think this will be a great way for us to learn from one another and to kind of get beyond the assumptions of what we think our disciplines do and really learn from the experts themselves. So with that, we will turn to our first poll question. Question 1, many people believe that my profession, I'm sorry, I just got something that popped up on my screen. Many people believe that my profession is best exemplified by these two guys who are here to pump you up. What profession am I? And for those of you who don't quite get the reference, it is a vintage Saturday Night Live skit that so many of us of a certain age truly understand and probably are chuckling a little bit as we see it. So A, is this a personal trainer? B, a kinesiologist? C, an athletic trainer? Or D, a physical therapist? And you can go into the poll feature and answer the question. And Louisa, do I have to pull that up or?
Nope, it's up. You just can't see it since you're sharing your screen.
So if I can't see it, how am I supposed to know what the answers look like?
I can let you know what the percentages are if that works.
Okay, why don't we do that?
Yeah. So we're going to end the poll because it looks like everyone voted. And I'm going to share those results. So 46% of you said personal trainer, 6% said kinesiologist, 46% athletic trainer, and 2% physical therapist.
And the correct answer is athletic trainer. And Dr. Jamie Mansell is now going to talk with us a little bit about what it is that her field actually does. So Jamie, why don't you take it from here?
Sure. All of the people on the multiple choice answers have probably had that distinction at some point. So athletic trainers are healthcare professionals. We are recognized by the American Medical Association, and the American Academy of Pediatrics says that athletic trainers should be providing healthcare at every high school sporting event. So we are healthcare professionals that render service or treatment under the direction or in collaboration with a physician. So we don't do direct access, we work in collaboration with that physician. We are certified at the national level by the Board of Certification. And then at the state level, we are credentialed. And each individual state has different credentialing available. So in the state of Pennsylvania, we are licensed by either the State Board of Medicine or the State Board of Osteopathic Medicine. Some states, there is a registration process. Some states do their own certification. Most states have licensure. And then California is the only state that does not have any credentialing for athletic trainers. All right. So while we do know how to help pump people up, that is really not our job at all. What we're doing is really looking at injury and illness prevention, wellness promotion, education, emergent care, examination, clinical diagnosis of both injuries and illnesses, and then also therapeutic intervention and rehabilitation of those injuries and medical conditions. We will work often in collaboration with personal trainers or with certified strength and conditioning coaches on more of that aspect. Traditionally, athletic trainers are employed in high schools, colleges, and professional sports, performing arts and clinic settings. And we have actually been what we call emerging settings. But now I think we're all kind of saying we've emerged, we're here. We work in the military, in hospitals and emergency rooms, particularly in hospitals that have a lot of orthopedic things coming in. Athletic trainers will often take some of the orthopedic side in the ER. We're in industrial settings, like large corporations that want to keep their workers safe. So Amazon, Frito-Lay, those types of places around here, Boeing, they hire ATs to do the injury evaluations, but then they also kind of examine what the workers are doing ergonomically every day to see if there's ways that we can reduce injuries in those settings as well. And then we also work in public safety. So with police, fire, et cetera, again, doing the injury evaluations, but then also doing some form of prevention for those as well. And I will also say that you don't have to like sports in order to be an athletic trainer. I was actually texting Dr. Chessman when this was going on, saying the AT program director just had to Google who's in the Super Bowl. I don't like sports, but I like the medical aspect. I like the community, and that's what got me into this. And I'll also put a plug in for the athletic trainers that are doing the Super Bowl, that are working in the Super Bowl this weekend. We are making some history because there are 3 female athletic trainers on the field during the Super Bowl this year. First time that we've had that many women represented in that arena. The first female AT in the NFL was in 1997. First full-time wasn't until 2002. So we're kind of making some strides in the professional sports arena.
That's great. Well, thanks, Dr. Mansell. I appreciate it. And we will have time at the end for a bit of, for either questions that people have or discussion of the different disciplines. So let's move on to question 2. So people assume that professionals in my field are pain and torture specialists. Am I a recreational therapist, an occupational therapist, a physical therapist, or a speech and language pathologist? All right, so Louisa, I've got this one. So in this one, we've got a landslide. So 93% of you said it's a physical therapist. A handful of you said an occupational therapist, and one of you said a speech and language pathologist. None of you thought it was a recreational therapist. So I assume that recreational therapists are actually the touchy-feely nice profession among all of our different disciplines. So with that, I'm going to turn things over to Dr. Scott Burns, who's going to talk to us a little bit about what it is that physical therapists actually do. Dr. Burns?
Hi, everybody. Thanks for having me on, and hopefully you can all hear me. And yeah, we always get the rap for being pain and torture specialists. Usually if you go outside and you start talking to anybody about any injury they've ever had, and then all of a sudden they're like, oh, I went to PT and it was a horrible experience. So generally speaking, we are known as that, and the acronym pain and torture is also our acronym of PT as well. So we also do get sometimes with athletic trainers and personal trainers, those are probably our two foremost professions that we are oftentimes mistaken for. But physical therapists do a lot more than pain and torture. I can't see myself, so I don't know if you can see my background, but that's our national organization. It says physical therapists improve the way you move. So they're movement experts who improve the quality of life through exercise, using your hands, and then providing educational elements for their clients and or patients. They pretty much work across the gamut. They work in the neonatal intensive care unit all the way up to hospice care and pretty much everything in between. Most people view the pain and torture folks as being the outpatient orthopedic after a surgery. That's generally where you see it. That's where most people have experience with it, whether you had an injury in high school or somewhere along the way. That's generally your first exposure. But they work with people that have strokes, that have dementia, that have multiple sclerosis. They also work with sports teams. They also work in military. They work in ERs. They work all over the different place. So the whole goal of physical therapists across the spectrum is to help the person move. And that could be a variety of things. Like it could be improving sports performance all the way to they had a stroke and no longer can use one side of their body. So it's a variety of different places that they work with. They also help children with different disabilities or conditions they may have. Physical therapists are a licensed profession. So we have a licensure exam. So you have a 2.5 to 3 year program. You can see Temple stuff up there. There are post-professional opportunities as well as fellowships beyond that, similar to medicine. But it is a licensed profession, and we do have direct access now in all 50 states. So you can actually see a physical therapist before you see a physician, which is a relatively new development over the last probably decade or two. So we're definitely moving forward in that round. And then post-professionally, we're starting to get a lot of individuals that after your entry-level doctorate of physical therapy training, they go into post-professional residencies, fellowships, or other degrees. And I think the next slide has, I don't know if I can control it. These are all the different practice settings that folks can be in: academics, acute critical care, athletics, federal. Prison systems is actually an up and coming area where they're doing a lot of this stuff. Schools, industrial, like Dr. Mansell was saying. And then some of the specialties, I think, is on the next slide. It ranges quite a big gamut. So the physical therapists are they're generally thought to be those pain and torture specialists. We work now in oncology, women's health or pelvic health, wound care management for individuals with diabetes. We work within pediatric settings, geriatric. We have folks working with cardiovascular pulmonary lung transplant teams. A lot of different areas of specialization in areas of movement that this one single license can cover. So I think is there anything after that? I think that's the majority.
No, I think that might be it. Great. Well, thank you, Dr. Burns. I appreciate that. So let's move on to question 3. Many people believe that my profession works by having people lie down on a couch and talk about their dreams. Over time, we ultimately blame everything on their mothers. Which profession am I? Am I a social worker, a nurse, a health psychologist, or an occupational therapist? So most of our votes are in, and 73% of you said that this describes a health psychologist, which is the correct answer. A quarter of you said that this describes a social worker. And for social workers who work in providing psychotherapy, that actually is a pretty accurate description, because that's what I'm sharing with all of you. So while many of you know me from my role in terms of responsibilities for our research mission and my directorship of CORE, I am a licensed clinical health psychologist and was seeing patients in the 20 years that I was across town at the University of Pennsylvania. I've maintained my license while I've been here with all of you, in part because in some of my research studies, we still deal with issues around study participants with significant psychopathology, and I'm mentoring postdoctoral fellows. And so I think it's important that I maintain my licensure in case we deal with a psychiatric emergency. But health psychologists, and there are several of us across the college, we study the psychological influences on people's health as well as their well-being. We typically focus on how it is that people stay healthy, particularly in relationship to environmental contributions that can threaten good health. We try to understand why it is that some people become ill and others do not. And then also many of us spend time focusing on how do people respond once they become ill, how do they respond to our treatments, and how do they recover over time. And we really focus our interests in both acute as well as chronic illnesses. So over time, health psychologists have worked on things like influenza, tuberculosis. There are a number of health psychologists, and I was part of a group last year that wrote an editorial on how health psychologists have been underutilized in response to the COVID pandemic. But we know that infectious diseases is a big part of the cornerstone of so much of public health in general. We also see health psychologists work in a variety of different areas around chronic illnesses. So whether it's obesity and heart disease, cancer, sexually transmitted infections, depressions, and even things like gun violence. So we typically will work in an area or a disease or a condition, and that will be kind of the cornerstone of where we work, and then sometimes take our expertise and training and bring it to other settings. Like we heard from both Dr. Mansell and Dr. Burns, most people who work as health psychologists are trained to the doctoral level and then licensed in the state in which they practice. So my license is in Pennsylvania. Many people, though, particularly when they live close to a state border, will get licensure in New Jersey or Delaware or New York and maintain multiple state licenses. And they work, as you could see, in a variety of different domains. So focusing on the etiology of a disease, the prevention and treatment of an illness, health promotion and maintenance more generally. And then increasingly, we're seeing health psychologists work on the formation of healthcare policy, as well as the improvement of healthcare systems. So it's not uncommon to see a health psychologist who will be working at a high level of a medical school or an academic medical center, working with the physicians to understand the mental health overlay with some of the physical conditions that are commonly treated. And I think that leads us to question 4. I lead bingo, plan birthday parties, and conduct Bible study, also known as the 3 Bs. We are just fun and games in my field. Who am I? Am I A, a social worker, B, a recreational therapist, C, an occupational therapist, or D, a physical therapist? Luisa, I lost the poll again. Can you throw it back up? Or at least tell me when we get to the point of who wins?
Yeah, absolutely. Okay, it just ended it. The percentage was 15% for social work, 82% for recreational therapists, and 3% for occupational therapists.
And the correct answer is recreational therapist. And Ann Doloff from the Department of Health and Rehabilitation Sciences is going to tell us a little bit about what recreational therapists actually do. Ann?
Thank you so much. So we're never going to shake the bingo responsibilities, and we're learning to just accept that as part of ours. But if you actually really critically assess bingo, there's a lot of outcomes that can be had from bingo. And people are obsessed with playing bingo, by the way. All ages, all populations, it doesn't matter. But we do use recreation, leisure, and activity-based interventions as our means of working with individuals with disabilities and illnesses to increase or enhance or maintain health and well-being. And I challenge all of you to think about, especially in the past year, how you have used some form of leisure in self-treatment and in maintaining your own health and well-being during these like incredibly challenging times. I know for myself, being out of doors, especially when we can't be with people all the time, and for me, especially being in nature, was incredibly powerful in terms of just regenerating myself, getting myself back calm, collected, cool, all those good things. So we tend to, so if you think about that in terms of how you use it for yourself, you can see how that can translate to being incredibly powerful when working with individuals with disabilities and illnesses. So we assess, we plan and design treatment plans, we implement those sessions, we evaluate the progress toward individualized or group outcomes, and using recreation and leisure as our means of intervention. So we try to really make sure in our assessment process that we're looking at what people already enjoy doing, the reasons why they enjoy doing what they're doing, so that we can design interventions that tap into individualized motivation and be able to increase that engagement so that we can really achieve those outcomes that enhance physical, cognitive, emotional, social, and leisure development to be fully engaged with their lives. So who are we as a field? A CTRS, a Certified Therapeutic Recreation Specialist.
Did we lose Anne?
I think we might have lost Anne.
We did. You know what? I can take over for her until she comes back.
Heather, you're my hero.
Yes, so not a problem at all. So Certified Therapeutic Recreation Specialist, we have to complete a clinical internship of 560 hours. At Temple, we do up to 600. And we have a minimum of a bachelor's degree, although many of us have a master's degree as well. You have to complete a national competency exam after your bachelor's degree, master's degree, and clinical internship. And several states also require licensure. And I see that you're back. I don't know if we can hear you yet, but I figured I would keep the ball rolling for us.
Oh, Heather, thank you. We pass off a lot to each other. Yeah, I'm getting that notice of unstable internet connection that we all love seeing, especially during class. That's really fun. So Heather did a great explanation of that. Thank you. We practice in multiple settings, basically where there's healthcare and human services or educational services. You might find a recreational therapist employed. I spent most of my career in nonprofits, working in the summer camp industry, as well as year-round recreational opportunities for kids and teens and their families. So how is recreation therapeutic? We have the evidence that talks about how powerful leisure can be, and yet we have a habit to put it always at the bottom of our priority list. Let's face it, we do that. As rec therapists, we do that. But we know that we can enhance physical outcomes from participation, mean enhanced physical activity, stress reduction, enhancing those social interactions, cognitive engagement, coping strategies. I asked you to think about that in terms of your own self-treatment. Creative and artistic expressions, learning new skills. Oftentimes when we set our personal goals, I hope some of you are doing that in terms of expanding your leisure repertoire, like what do we want to do next? And then it certainly contributes to independence. We teach self-advocacy skills. We do a lot around social skills, improving executive functioning skills, increasing our social support networks, enhancing motivation, especially when people are really struggling with that, and contributing that sense of self-worth, and like we all do, hoping that improves our general quality of life. But we really are more than bingo.
And, you know, from now on, I will always think of you guys as the profession with phenomenal teamwork, given how Heather just stepped in there and picked up the ball so gracefully when you had your tech issue. So that was fantastic, guys. Thank you.
You're welcome.
So question 5, people assume that professionals in my field come to work and play games all day long. We are personal trainers who work with athletes or healthy adults. Which field am I? Am I an athletic trainer, an exercise scientist, a physical therapist, an occupational therapist, or a recreational therapist? So we've got a nice bit of variability with this one. So 60% of you said that the correct answer is exercise scientist, but 16% said occupational therapist, 9% said recreational therapist, and 14% said athletic trainer. And the correct answer actually is exercise scientist. And so Dr. Sarah Kovacs from the Department of Kinesiology will go ahead and tell us a little bit about what exercise scientists do. Sarah?
Absolutely. Thank you for having me here. And I have to tell you that that was a misconception that I had heard as a student. I really felt like I was promised the opportunity to wear gym clothes and play games. And that is definitely not what we do. It's a component though, as exciting as that is. So what's really exciting about exercise science is that it's actually a subdiscipline, or just one component of the study or the discipline of kinesiology. And as you see here, kinesiology truly does stand for the study of human movement. So within kinesiology, as well as within exercise science, our focus really is on movement and outcome of regular movement, so physical activity and exercise. As I mentioned, kinesiology includes multiple subdisciplines, and those subdisciplines are listed for you here. We often actually think about kinesiology as more so of an umbrella term. So what are these subdisciplines? What do kinesiologists and exercise scientists study? Within these subdisciplines, we often find exercise physiology, and exercise physiology really is the focus for exercise scientists within that profession. Exercise physiology takes a really deep dive on the body's physiological responses to movement. What are metabolic, cardiovascular, and respiratory outcomes that result from both acute as well as chronic participation in physical activity and exercise? We also do our homework. There's some subdiscipline focused in on history, philosophy, and psychology. So we do want to, as strong kinesiologists, think about what factors are going to influence an individual's participation in movement. There is a subdiscipline that's really focused in on psychology of activity, and some of these individuals who really specialize in this subdiscipline of kinesiology may be found within the context of a sports team. They are going to really focus in on mental and motivational factors that really play into an individual's physical activity or sport performance outcomes. In addition to these subdisciplines, we also focus in within kinesiology on motor learning and development. How are motor skills learned and how do they develop across the lifespan? We can think about biomechanics. Many of you have heard, I'm sure, someone critique form for a squat or a push-up. What are they really focusing in on? they're focusing in on correct form and underlying the subdiscipline biomechanics because we can ensure that individuals are being active in a safe and effective way. And lastly, we're within the College of Public Health, and I love that kinesiology is housed here because as kinesiologists, as exercise scientists, we really look to promote physical activity at a population level and promote the message that movement can be medicine. So where can you find kinesiology professionals? They can be found working with a variety of populations in a variety of settings. There are some clinical specialists who focus in on the cellular level and outcomes we see at the cellular level. We see some studies in kinesiology within animal models, but they also have the opportunity to work with those healthy and active populations, clinical populations, and large groups population scale interventions for physical activity as well. Across all of these subdisciplines, kinesiology and the discipline of kinesiology really has one ultimate goal, and that ultimate goal is to help the population and individuals to be active and really achieve optimal health through regular movement and physical activity.
Well, thanks, Dr. Kovacs. That was great. Now let's move on to question 6. Many people believe that my profession thinks that the solution to all of the problems in healthcare can be fixed by more data entry by healthcare providers. Which profession am I? Am I a healthcare chief financial officer, a health information management professional, a public health specialist, or a social worker? And this one is a landslide. So 92% of you got it right, that what we're seeing here is a description of a health information management professional. A few of you said a public health specialist or a social worker, but now it's my pleasure to introduce Dr. Maggie Foley, who is going to tell us, if I can advance the slide, what exactly it is that health information management professionals do. Dr. Foley?
Thanks, Dave. Hello, everyone. I want to give you a sense with this diagram that we describe health information management as the area where healthcare, business, law, and technology all intersect. So when we think about it, the essential role of your health record, be you the individual healthcare provider or the patient, is that communication tool. So what was diagnosed as your problem, what treatments were rendered, what was your response to the treatment, and then think of it too as we're handing a patient off from one care provider to another or one location to another, that quality information is essential to quality healthcare. So when we think about it at the individual patient level, it's very important. And then when we start to look at the data at an aggregate level, it too is essential when we start to look at improving health outcomes and even in demonstrating value in care that's been provided. Want to try the next one, Dave?
Sure.
So when we think about our educational program, you may hear it referred to as either health information or health informatics. There are programs available at both the bachelor's and master's level. And our educational programs attract a broad range of students with a variety of interest because of those many areas in which we intersect. So if you have an interest in healthcare, in information technology, law, all of those things kind of blend together to create what we do every day. So on this slide, I just tried to give you a flavor of some of the jobs that our graduates obtain. So whether it's a data analytics to improve healthcare quality or safety, so at more of an aggregate level, or even in terms of demonstrating the outcomes for a healthcare provider who may be evaluated by others. We are in an exciting time within our field because health information exchange and the use of electronic health records are really getting beyond their infancy to some exciting applications that may be either provider facing or patient facing. There's great concern regarding patient privacy and the need for security of health information. And then just on the end, I already touched on these issues, but the essential need that the record be a reflection of the patient's story, and that it serves as a useful communication tool, whether that's to the next healthcare provider or even to the payers who are evaluating the care provided and paying for the services.
Thanks, Dr. Foley. So question 7, people assume that professionals in my field are looking to reduce healthcare spending at all costs, strip clinicians of their autonomy, and tell everyone else in healthcare how to do their job. Who am I? Am I a health services researcher, a health information management professional, a hospital administrator, or am I a department chair? So for the first time today, the wisdom of the masses is incorrect. So a majority of you said that, 57% of you said that this describes a hospital administrator. A third of you described this as a health services researcher, which is the correct answer. And with that, I'm going to turn things over to Dr. Eileen Holland, who's going to tell us a little bit more about what it is that health services researchers do. Dr. Holland?
Thanks, David. Those results don't surprise me. They kind of track with people not understanding what health services research is. So let me tell you a little bit about health services research, or HSR, which is easier to say. So HSR really looks at how people interact with the healthcare system in terms of how they access the system, how they pay for healthcare, and what happens to them as a result of their care. So by this, I really mean like their outcomes. So when we look at these things, we are really trying to identify the most effective way to deliver healthcare. And the goals of HSR tend to be ambitious. It's to make the organization, management, finance, and delivery of healthcare more effective. We focus on how to deliver high quality care, reduce medical errors, improve patient safety, and the like. And finally, HSR aims to impact healthcare policy and practice. So just like in the lab sciences, in which we have to think about how to get treatments from bench to bedside, in HSR, we also aim to have our findings about effective care delivery implemented into the healthcare system. Great. So because HSR deals with the healthcare system and the system touches patients of all kinds, it can be applied to many different patient populations. So as a result, you'll often find that people in HSR tend to not necessarily focus on a particular condition and maybe more focused on specific aspects of the healthcare system, like insurance benefit design or physician payment practices in primary care. That being said, many health services researchers do specialize in a particular condition or a group of conditions. So for instance, like I myself have done a lot of work in complex chronic conditions and rare diseases. The outcomes that we focus on can be broadly categorized as value outcomes like efficiency, quality of care outcomes, such as getting people the right care at the right time, and effectiveness outcomes like health status. And notice that I said effectiveness and not efficacy. And this is because in HSR, we focus on real world settings. Much of what we study can't be examined in a clinical trial setting because it would be impractical or unethical to do so. So we often rely on observational data or secondary analyses of existing data sets, such as insurance claims, EHR data, or large national surveys. And so as a result, we typically have experience working with very large data sets. And one aspect of HSR that is particularly relevant for those of you in other disciplines is that it tends to be very interdisciplinary. We work with health practitioners, policy folks, health IT specialists, Because we typically have more expertise in aspects of the healthcare system. We really rely heavily on collaborations with others who have more expertise into the particulars of a disease or a patient population. I, for instance, my training is in health economics and policy, but I view myself as a health services researcher because it's more aligned with my goals. And I view my economics training as a tool to facilitate that research. And you'll encounter us in a variety of settings. Research is in the title, so we're often in research environments like a university, but we're also found out in policy settings or in-house for like healthcare stakeholders, such as in hospitals, insurance companies, or pharmaceutical companies. So lastly, because I mentioned that we're typically experts in a specific aspect of the healthcare system, I just wanted to show you what some of those aspects might be and quickly just say a word or two about each of them. So the first two, high value healthcare and cost effectiveness, are about getting the greatest return on our investments in healthcare while also providing effective, high quality care. Access and disparities work are focused on equity and the distribution of healthcare. Payment is about how we pay clinicians and other providers. You might be familiar with terms like pay for performance or accountable care organizations. Delivery models are about how care is actually fulfilled. So you may have heard about a model like the patient-centered medical home. That would be an example. And the study of insurance and benefit designs looks at how to structure insurance plans to balance appropriate levels of coverage so people get the care they need, but balanced against incentive structures so that people don't overutilize healthcare or waste resources on ineffective care. And finally, decision-making is about how stakeholders within the healthcare system, and this includes all stakeholders, including patients and families, make decisions about the care that they receive.
Great. Well, thank you, Dr. Holland. So as we move on to our last question, if you have follow-up questions or comments or discussion points for any of our panelists, feel free to start putting them in the chat feature. Once we go through these last slides, I'll pull the chat feature up on my end so I can begin to see and moderate that discussion. So for our last question, people, or at least members of my family, assume that all people engage in field travel to different countries on the hunt for sneaky monkeys, steal military helicopters, and save the world from deadly viruses all in the nick of time. What profession am I? Am I an adventure travel blogger, an epidemiologist, a social worker, or the associate dean for research? So as much as I would love to say that that's in my job description, unfortunately it's not. And 93% of you got it right, that this actually describes an epidemiologist. And it's my pleasure to turn things over to Dr. Erin Kulik, a new member of the faculty in the Department of Epidemiology and Biostatistics, who's going to tell us a little bit about what epidemiologists actually do. Erin?
Thanks. I just want to give a huge shout out to COVID, because before, I think the last year, many more people would have guessed, oh, they work with skin, or, oh, like the movie Outbreak. Yeah, I get it. That's exactly what you do. So now 93% of you don't doubt it. So that's much more than before. So what we actually do in epidemiology, and while some people do chase monkeys like in the movie Outbreak, most of us do not. It really is a discipline that looks at the health of populations, kind of in comparison to medicine, which tends to look at the health of like an individual. So both kind of in the study in health events and diseases, we use the classic 5 W's that I think we probably all learned in grade school. We figure out what disease or what event is happening and impacting a population. We look at where it's happening. We ask kind of when is it happening and to how many people, and then how it's happening. So kind of whether that's identifying things like risk factors for dementia or trying to figure out how respiratory diseases like COVID are spreading throughout the whole world. And then the other big component in EPI is the application of what we find. So once we figure out what's going on, of course, we then want to figure out how to intervene and stop these adverse health effects. And we do all of this stuff primarily by using, collecting, and analyzing data and interpreting it. And personally, that's a large part of my day-to-day work. And I think what's so cool about EPI, for me at least, is that it incorporates methods from so many different fields, many of which we've already talked about today. So biostatistics, health informatics, biology, medicine, and a lot of the social and behavioral sciences all kind of are incorporated into this field. And there really are so many places that epidemiologists work, and many have been in the news a lot today. And obviously they're in academic settings such as Temple, a lot of government organizations like, yeah, I see a comment, Dr. Fauci, of course, like the CDC, NIH, there's epidemiologists in state and local public health departments, which I've worked before, in pharmaceutical industries, which are heroes these days, in hospitals as infection control EPIs, and then the field epidemiologists, which, you know, will go out and chase the viruses. Now, whether they get to do cool things like in the movie, maybe, maybe not.
So thank you, Dr. Kulik. I appreciate that. So I'm gonna pull up the chat feature here so I can see some of the questions that people have, because I don't have all of you up on my screen. So let me see if we have some questions here that are already embedded in the chat. If you asked me, if you asked me something more than say 15 minutes ago, please go ahead and post it again. I'm seeing a lot of nice comments about the presentation, which are really great. So I'm gonna go ahead and start then with the first question. And Dr. Mansell and Dr. Burns, this is really to both of you. Can both of you comment a little bit about how licensure works? For example, if you're an athletic trainer with a sports team that goes across a state line, are you able to provide services in that other state? So if you're licensed in Pennsylvania and your team is playing in New Jersey, I assume you're allowed to go help an injured player in a game. This is an issue that psychologists wrestle with a fair amount too, particularly again, when you are near a state line.
That is a great question, and something that has only been resolved for a few years. Something called the Sports Medicine Licensure Clarity Act came out, I think it was 2019, that allows us to be able to render our care across state lines to our own patient population. And that means that whatever we're allowed to do in our home state that we're licensed in, we're able then to do in the state that we're traveling to.
Okay. And Scott, is that true for PT as well?
It's similar. It's moving in that direction. They have what's now called the Physical Therapy Licensure Compact, which is a number of states. I think we're about halfway through all 50, where if you hold a license in one state, you can then do exactly what Dr. Mansell said, is travel across with that team, do what you need to do, and then come back.
Okay. And Scott, we don't have a hard stop at 2 o'clock. So if people have other questions and we can go a little bit beyond 2, that's perfectly fine. But Scott, I'm going to stay with you for just a minute. You mentioned this idea in your presentation that people can now come to see a physical therapist before actually seeing a physician. And I've heard other people talk about this as well. And I think I've actually had discussions with members of your faculty about this. Putting on my patient hat, that seems counterintuitive to me. Like, I don't know if I would go and see a physical therapy. You know, if I have a knee injury, and I did several years ago, I don't think I would even think to go see a physical therapist until I saw an orthopedic surgeon and who said, yes, go see a physical therapist. So can you tell me a little bit about how the field, how the field is kind of, trying to promote that approach, and what are the pros and cons of that?
Yeah, absolutely. So yeah, direct access is what it's called now, and it's a relatively new thing to healthcare, I should say. So what you're speaking about is, the traditional medical model where the physician will be at the top and then they direct care down below. And that still happens, and it's still very pervasive. What we are starting to see is that puts a lot of load at the top, particularly with that physician, that they have to then know exactly what to do. So in some cases if you just had a basic knee injury, and let's say it wasn't traumatic, you weren't in an accident, most likely they're going to send you to physical therapy. So it's a way to chop off about a month, which now some of the data is showing the faster you get into certain things, particularly physical therapy, the faster you actually can get rid of some of your conditions. So I think there's it's quicker access to service. It's also reducing the burden on the primary care and or orthopedic physicians. And in some cases, there are certain conditions, particularly I'll call out spinal pain, and low back pain is my area of most expertise. When you go to an orthopedic surgeon, unless it has certain things, it's actually could be detrimental in some fashion, because if you get a picture of what it looks like, you might actually end up having a surgery that we don't know whether it'll help. So, definitely not trying to promote that PT should be the first and foremost for everything. If someone's having an acute stroke, please don't show up to a physical therapy office. Obviously, go to where you need to go. But I think the physical therapists are also trained. And if you were to see a physical therapist direct access, and I've had to do this where I do not feel like you're appropriate, you then have to go, I will refer you to the physician and say, you need to go see the physician first. The other thing I would say is it's not like it's open-ended either, where you can just see a PT, but it's very similar to how chiropractic is set up, where you can go see them at any point. We have to then report it back to your physician, and if they agree, they will then sign off on your ability to stay with that physical therapist.
Yeah, there's thank you for that, Scott. There's a range of opinions being expressed in the chat about who would people go see, and not only is your field getting a bunch of shout outs, but you personally are getting a bunch of shout outs in the chat. I think you've become the resident physical therapist for a majority of or a large percentage of the faculty at this point. One comment that has been made is, why were some of our other disciplines not represented? All of our fields, all of our disciplines were invited to participate. Unfortunately, some of them, for reasons that I can't explain, elected not to. So I'm hopefully, if we repeat this at some point in time in the future or next year, we can actually get our disciplines and our departments that didn't offer to participate today to do that at some point in time in the future. So a question that came up from Jen Ibrahim to all of you is, and I'll open it up to the entire panel, can all of you comment a little bit on how your field is really embracing public health? Health psychologists, for example, we oftentimes are very clinically focused. And one of my great joys in joining the college was that coming and being in this environment has really been a catalyst to me to think about obesity from a different perspective, and much more as a public health condition than an individual condition. But for all the panelists, can you comment a little bit about how your discipline is really kind of embracing public health in our college?
I'll be glad to go first on that, because I think it's sometimes confusing with rec therapy, but we're talking about a group of individuals, the population we typically deal with in terms of people with disabilities, always being viewed as in great need of healthcare, and even to the extent of being a burden on the healthcare system and requiring that. And we don't look at oftentimes people with disabilities from a health and wellness perspective. And I think that's where I'm excited as a rec therapist and as an instructor in the program to be in the College of Public Health, because we really can come at it from a health and wellness perspective, and also health and wellness can coexist with illness and disability. That to me, I think it's just a great fit. And I think that's a perspective that we have in our field, and I hope we can bring to the table in public health.
Yeah, I really like the way you articulated that, Ann.
Well, thank you.
What about for the rest of our panelists?
This is Maggie. I'll just take, obviously, I'll say information is power, but I'm recently working with a group specifically related to the better capture of social determinants of health in a standardized format. So whether that's the immediate assessment of a social risk, what sort of goals are established for the patient, and then can we monitor the progression, what interventions work, and you can do that at an individual level, but then roll it up to an aggregate level for public health analysis.
I think from the athletic training standpoint, we are in the community. We are often sometimes individuals' first entry into the healthcare system, particularly thinking about rural or urban school districts. The AT might be the only healthcare provider that students see or patients see to kind of help them enter in. We're also a great referral system. And since the pandemic started, athletic trainers who were traditionally hired in schools or hospital settings have been kind of redeployed to do testing and vaccinating in some communities as well.
Yeah, that's great. And as soon as you said that, I began to wonder if you're an athletic trainer in a high school and many of your teams have had suspended seasons, what's happening to people. So I'm glad to hear that there's the deployment to issues around COVID in the schools. Maggie, I have another question for you on a different topic. Can you share with us at all the challenges of doing the type of work that you do in the United States as compared to, say, if our approach to medical records was more akin to what we see in Europe?
We are highly regulated. So from a payment perspective and from licensure perspectives, sometimes the idyllic goal of truly just capturing information on the patient and as a communication tool, it sometimes gets morphed into a billing form, trying to meet some regulation by somebody checking off a box. So it's very difficult. As I did mention earlier, though, we've implemented some of the baseline electronic health record technology. We're finally getting to the exciting piece where we're getting better at health information exchange, trying to standardize how we capture information, still be able to tell the patient's story, and then meet some of those secondary needs. Many other countries, if it is a single payer, they're not trying to, pay off Caesar with the regulatory requirements, and then the 14 other insurance companies that may be asking for something slightly differently. So it can be very challenging with lots of different rules and requirements out there.
Okay. Mm-hmm. And then I want to stay with your HSAP colleague for just a moment. And Eileen, I have a question for you. Can you comment a little bit for all of us on kind of the tension between evidence-based healthcare and what some physicians still like to refer to as the art of medicine? So, in the field where I do some work with plastic surgeons are still very much used to talking about what they do has art to it, and they've been kind of slow to embrace evidence-based practices. They've been slow to talk about evidence-based medicine. But you made it very clear that so much of what you do is using the evidence base to guide best practices. But how much tension is there in a healthcare system between people like yourself who want to use that evidence base versus maybe that different guard, an older guard that still believes in the art of medicine?
Yeah, I think that tension does exist. And I think, of course, it depends on who you talk to, and some people are more open to it than others. But there's a lot that we know from health services research that we can point out in terms of how there are different patterns of utilization across different geographies and things like that. And when we encounter that information and are able to bring it to people, I think one of the challenges is that a lot of healthcare practitioners tend to think that they are and their population that they provide for are somehow different than the populations that are necessarily being studied. And so I think that that can be a tension at times. And I think some of it is related a little bit just to autonomy and to the de facto response to tending to wanting to do things how they've been done in the past. So there definitely, I think, is a tension there, but I think that it's sort of moving in the right direction.
Good. So as we wind things down, I want to once again thank all of our panelists. I think you all did a wonderful job. I very much appreciate your willingness to come at this with tongue fully in cheek and have a little fun with this as we learn from one another. I hope, unfortunately, I wasn't able to see the Brady Bunch Hollywood Square version of all of you to see how many laughs and chuckles we had along the way. But I hope, you know, in the spirit of the times that we're in, everyone had an opportunity to laugh and smile. And now that I do have all of you up, I can say it is actually wonderful to see so many faces of people I haven't really seen in quite some time. So I hope that this really kind of is a nice way for us to start our IPE-based discussions this year, and something that Sue and Jen and I are really excited about doing in the months to come. So with that, I'm going to hand things over to Jen just for a moment, and she's going to explain a little bit about our session next week, which is going to involve the guest presenter who's going to take us through a bit of a problem-solving exercise. So Jen?
Sure. So it's actually going to be in 2 weeks on the 19th.
Thank you.
When you said that, I had to look at my watch. I was like, wait, what is today?
No,
so on the 19th.
You're absolutely right. Sorry about that panic
No
attack.
problem. No, it was more panic for me than anything else. On the 19th, we're actually going to have a former public health official from the state of North Carolina. He has been retired for a few years now. But I actually did a site visit with him in December, and he really wrote this really great interprofessional case study on COVID. And we're going to use this as a launching point. He's going to walk us through this case study. There'll be some opportunities for questions, for interaction. He'll be posing some different questions, thinking about the roles and the responsibilities and some of the ethical issues that we all play in this, not only in our silos, but where we actually have some ethical obligations to work with each other to maximize the limited resources that we have. So his name is Fred Pilkington. He will be walking us through this. It'll be about maybe 60 to 75 minutes. So just anticipate that it will go a little bit past the 2 o'clock. But what's exciting is we will be also using this as a kickoff for a case competition that will be coming out. More information will be coming out in the next week or two. And so we actually are going to be using this kickoff as a way to encourage our students to get into interprofessional teams and to work through some of the challenges that are posed in that case study. And this competition will run through the month of March, and then we're going to be showcasing what solutions the students come up with to COVID. So looking at issues not just right now of vaccination, but also thinking about rehab and thinking about that post-COVID era. So you can look for more information on that coming out within the next week or so. So I think that's something that should be pretty exciting. I always like it when we throw a challenge out to students. They never cease to amaze me when they knock it out of the park and come up with things that we've never even considered. So I invite you back in 2 weeks. We will send a flyer out to everyone. Please feel free to share the link with whoever you want, and we will send out a abridged version of the case study in advance. And then I have permission to share the entire case study with everyone after the 19th, if it's something that you want to continue to chew on with your students in classes.
Yeah, I'm particularly excited about this. I think it's going to be a really fun exercise, and a fun exercise for us to take on with our students. Louisa did just put the link to the event on the 19th in the chat. So if anybody wants to register right there, it is there. And I'm going to babble for a few more moments in case you want to register on the fly. But next week event, actually, Heather Gardner's office has invited a program officer from PCORI to come and talk to us about strategies to pursue PCORI grants. Many of you know that this is another major funding mechanism that aligns very, very nicely with a lot of the work that we do across the college. And we're actually going to have 2 additional events in April, which will be focused more on our community, looking at and brainstorming potential opportunities where we can come together and submit a multidisciplinary grant that would go to PCORI to fund some of our common interests. So with that, everybody, I want to thank you again for joining us. Thanks again to our panel who were fantastic and delivered. If you didn't recognize the Pump You Up guys, I trust that all of you will go and spend the rest of the afternoon YouTubing old clips of them. It actually, just appreciate that at the time, it was kind of the, for a while, it was like one of the hottest skits on Saturday Night Live and one of the most popular ones. So otherwise, if you're a football fan, enjoy the Super Bowl. Hope we all get an entertaining game on Sunday. And otherwise, I look forward to seeing many of you again next Friday. Take care, everyone.